Ultrasound screening of abdominal aortic aneurysm by junior medical officers in Australian rural hospital setting, a pilot study by Dr. Vincent Chow and colleagues from St. Vincent's Hospital in Melbourne, Australia.
Hi, my name is Vincent, and I'm going to present my project on ultrasound screening of AAA by junior medical officers in Australian rural hospital setting. AAA is recognized as a serious and potentially fatal condition. In Australia, approximately 1,000 deaths per year are attributed to aortic aneurysms. The primary objective of this study is how reliable our measurements will be. We also looked into the scanning efficiency and aneurysm detection. This is a 23 days prospective study in a rural hospital in South Australia. 3 junior doctors who underwent a 2-hour practice ultrasound training scanned sequentially on participants who are greater than 50 years old. Each doctor is allocated a maximum of 10 minutes on each patient and is blind from each other's findings. Results are compared against the clinically acceptable difference of 5 millimeters. 71 individuals are scanned, which includes 26 inpatients and 45 volunteers. A total of 213 measurements were performed. There was 93 successful measurements attainment within 10 minutes. All 3 operators' measurements were within clinically acceptable difference from each other in 88% of the cases. We compared pairs of scanners using Bland-Ottmann's analysis, which showed excellent agreement on aneurysm detection between operators. It also showed that measurements reproducibility substantially improved after standardization of ultrasound technique. In terms of screening efficiency, we obtained 100% measurements from the 31st participant onwards, and we noted more efficient scanning with more practice. In terms of aneurysm detection, out of 71 participants, 5 AAAs were detected, 2 of which were new and 1 was agreed by a radiologist. While the other one was disagreed, a CT was recommended for further evaluation. The major limitation of this study is that there is no gold standard measurement due to the limitation of resources, which means the result could be reliable but inaccurate, as shown in the diagram on the right. However, this study does reinforce the cost-effectiveness of AAA screening that has already been shown in the UK, US, and Sweden. The cost per subject scanned was 13 Australian dollars only. This study provides important public health implications on AAA screening in rural settings, where access to prompt specialized care is difficult. We demonstrate that results are reproducible by junior medical officers who only received 2 hours of training. However, we do recommend a 1-day supervised practice. Future studies should include a multi-center study with comparison to professional sonographers to demonstrate accuracy of screening by novice in rural Australia. Thank you.
All right. Thank you for that excellent talk. Where do you hope to go with this? I mean, do you have clinics in the rural setting that the house officers can go to screen people? And how do you get people to come to these clinics?
Thank you very much for the question. I think that's a really good point because access to ultrasound machine in rural hospital can sometimes be difficult. In our scenario, we perform all our scans in the hospital inside. And practically, if we're gonna run a screening test, say in a rural hospital settings, we think that the next stage will be inviting participants to go into the hospital to have it scanned. But in the future, say if we're gonna extend the studies to a greater populations, we can definitely stand up a particular clinic for this ultrasound screening, and definitely will help with the accessibility of ultrasound screening.
So having residents do it, does that end up being cheaper than having just an ultrasound tech perform this in the lab?
Yes, absolutely. In particular, say, when we perform this study, we were actually still interns. The pay rate is definitely lower. And we think that the implication for this study is not only that the scan can be done by interns, but also mean that in future study, we can look into scan being done by other members of the hospital system, say nurses or allied health staff, or even medical students. And that's a really important point because throughout the studies, we found that performing the ultrasounds really help with the understanding of anatomy. And we think that it can actually help with medical students learning the anatomy of the abdominal cavity and raise their interest in future career in surgery.
So it can be a teaching exercise as well. I noticed you did have some positive ultrasounds. How did you select your patients again? Were they all high risk for aneurysms?
No, actually, because the time frame was only 23 days, we basically scanned everyone between the age of 50 to 70, and we didn't pre-select the patients. Basically, all the patients that we performed the ultrasounds on are either hospital inpatients or volunteers in the community. And a lot of them are actually females as well. So, I mean, the risk factors are not there, but we still perform that as a part of the screening. We think that the pickup rate was higher in our study, basically because of the patient demographic in the rural town that we were at, where a lot of the people that we screened on has a high rate of smoking, as well as high rate of obesity.
Dr. Nelson wanted me to ask you, what time is it there?
It's actually 2 a.m. I'm actually working in the hospital tonight as a night shift. I'm in the labor ward. That's why you see the uterus there at the back.
Well, thank you for staying up this late to answer questions. As I understand it, Jason Lee was up last night at 2 a.m. still anyway, so he's able to answer the questions. Do you have plans to expand the program to other parts of Australia or even international?
Yeah, I think that's a really good question because I think ultrasound screening for AAA was actually really a hot topic in Australia about 2 decades ago, but sort of cooled down ever since a randomized control study done in Western Australia, saying that there's no mortality benefits. But the study was actually done in a metropolitan settings. There hasn't really been any studies done in a rural setting, and that's why we performed this study. And we think that in future study, we definitely should extend the study to greater, rural or remote communities where access to immediate AAA care is difficult. And yeah, that's where we think it should go towards in the future studies.
And then one final question. In the United States, we have a company called Lifeline and other companies that do screening of patients in the community for about $100 to $150. And so it's way cheaper than if they were to get all of their studies done in the hospital. Do you think that there is a role for trying to convince insurance companies or the government to pay for these less expensive exams as a way to monitor more patients or to screen more patients at a lower cost?
Well, I guess there are two factors into it because if private insurance companies are going to perform the scans, first things that we need to find out is really the quality as well as the overall efficiency of the scanning. I could imagine the cost will be cheaper, but at the same time, the waiting time might be longer and it's harder for quality assurance. But at the same time, I feel like it's probably going to be beneficial to the public because low cost meaning probably a higher participation rate. These studies, we offered the scan for free to the populations, and the result was really good. A lot of the patients, actually there was 100% participation rate, so everyone who signed up turned up and they were all really interested in the topic. So I think if the scan can be done in a community at low cost, that would definitely encourage a population to perform that, to have the scan done.
Thank you for your excellent discussion. We'll throw it back to Jason.
Thank you.
Thanks, Mark. Thanks, Vincent. And I'm glad it's 2:30 a.m. over there. Starting tomorrow, I'm going to institute for the Stanford interns at 3 a.m. to check ABIs on everybody during pre-rounds.